thing about acid-base balance is 4 imbalances as opposed to all the different electrolytes and all that. So I think personally acid-base balance is a little bit easier. And at the end of the time, we're going to learn how to read ABGs. And we're going to do a little thing called Name the Baby. And you're going to learn, there's a little video that goes along with it, and you're going to learn how to read ABGs using that. I wrote up here on the board respiratory and metabolic, because that's the 2 areas that when you're talking about acid-base balance, that's the 2 areas that we look at. We look at respiratory, the lungs, specifically CO2. We don't really think about O2 as much. We think about CO2. Oh, I need to sneeze. I hate that feeling. And it won't, I can't say. Oh, okay. And then metabolic, we think about the kidneys. And we're going to be talking about bicarbonate. And bicarbonate is excreted in the kidneys or conserved by the kidneys. And so those are the specific things that we're going to be looking at, CO2 and bicarbonate. Now, did you talk about acid-base balance a little bit in anatomy and physiology? Yes. And I know Mr. Henley does a little something with ABGs as well. So mine's going to be a little different than his, but if you understand how to do his, you should be okay. When the body is trying to compensate, when it's trying to balance itself out, because remember, the body is constantly trying to get back to a state of homeostasis, right? We're trying to get constantly back. So if we are in a state of imbalance, acid-base imbalance, then it's going to buffer. It's going to send out buffers, specific type of buffers. Did y'all talk about that? In the body to try to take care of the situation. So if it's too acidic, if you've got an acid, what are you going to add? A base. Do y'all remember those experiments? Did y'all ever do one of those experiments where you have an acid in a little beaker and you add some base to it and makes it kind of milky looking? It decreases the acid. Now, if it's too basic, what are you going to add? Acid. So that's what we're going to be talking about when we talk about the buffer system. Now, these 2 little pictures, this one and the next one, are just kind of overviews, if you want to say it that way, of these imbalances. So we're going to look at each one of them specifically, but you can always come back to these. All right, so we're classified as either respiratory or metabolic. Respiratory disorders specifically impair gas exchange in the lungs. When we're talking about gas exchange, what gases are we talking about? Oxygen and carbon dioxide. So when you have some kind of respiratory problem, i.e. COPD or emphysema or asthma or pneumonia or something like that, it impairs that process in the lungs. And it will cause either the retention of CO2 when you keep too much CO2, and that's called acidosis, or it will cause an excessive loss of CO2, and that's called alkalosis. Metabolic disorders cause either an excessive production of hydrogen ions or an excessive loss of hydrogen ions. Okay? An excessive production of hydrogen ions would be acidosis, and an excessive loss would be alkalosis. Okay? So far, so good? So, too much CO2 retention is acidosis. Too much CO2 loss is alkalosis. Too much hydrogen ion retention is acidosis in the kidneys. And too much hydrogen ion loss is alkalosis. Okay. Now, when we talk about compensation, and we're going to mention this quite a bit throughout all these disturbances, we're going to mention the process of compensation. Because your patients, again, the body is constantly trying to get back to a state of homeostasis, so it's going to be compensating using these buffers, right, to make the body back, to bring the body back into its normal state. Okay, so if you have a metabolic disturbance, the opposite is going to take effect. If you have a metabolic disturbance, the respiratory system is going to compensate. If you have a metabolic disturbance, the respiratory system is going to compensate. Okay? So either way, either if it's metabolic acidosis or metabolic alkalosis, the respiratory system is going to compensate. And it's going to compensate by either increasing your breathing or making it more shallow. Okay? Renal disorders, respiratory disorders will cause a metabolic response. So the kidneys are going to react by either increasing urination or decreasing urination, because they're going to try to either retain more bicarbonate or spill more bicarbonate. Okay, so the opposite. Now, some terms that you're going to hear, not necessarily right this in the next day or so, but when we do the name the baby ABGs, is complete compensation, partial compensation, and decompensation. Okay? Complete compensation means that whatever buffer system was needed, it has fully corrected the problem. And it has brought the pH level back to normal. Okay? Complete compensation means that the buffers have achieved homeostasis. They've done their job. And they have brought the pH back to normal in either respiratory or metabolic. Okay? So if you looked at an ABG and you look at the pH, it's either going to be acidic on the low end, alkalotic on the high end, or it's going to be normal. And if it's completely compensated, it's going to be back in the normal range. Okay? Partial compensation means that they are in the process of working. They're in the process of achieving homeostasis. So, for example, if on admission you have a patient with COPD and you get an ABG level, you're going to learn in just a minute that COPD is an example of respiratory acidosis. Okay? You draw an ABG level and the pH is acidic. And the CO2 is going to be very high. So the body is going to start, the kidneys are going to kick in. And the kidneys are going to have to spill more bicarbonate. If you do an ABG on the first day and you notice that the pH is acidic, and for some reason, I don't know why you want to, but you do an ABG on the second day, and it's still acidic, but it's not as bad as it was, that's partial compensation. Does that make sense? It's getting better. You see your numbers improving, but they haven't fully gotten back to normal. Make sense? Okay. So that's partial compensation. So that's a good thing because that means that the body is working. It's doing its thing. If you did an ABG on the first day and then another ABG 3 days later and you have seen no improvement, then something's not right. Something's not working. The buffers, the body is not kicking in the amount of buffers that it should be. Okay? You see that a lot with renal failure patients because their kidneys can't buffer. Their kidneys have no ability to buffer. And then the last state is decompensation. And of course, you never want anybody to decompensate. Decompensate means that you draw that ABG on the first day and you draw it again 3 days later and it's gotten worse. They're steadily going downhill. And in some of these chronic disease disorders, that's what's going to happen. You've got patients, COPD patients, for example, who you hear them classified as end-stage COPD. Those patients are decompensating. They're not getting better. And it's a chronic disease. They're not going to get better. So some of these things, renal failure patients, heart failure patients, those patients are not going to get better. And so eventually they're going to just start to decompensate. Their body can't react. It knows that there's an imbalance. It knows there's a problem, but it can't do anything about it. Okay? Make sense? So decompensating, of course, is a bad thing. You don't want to ever see it, hopefully. All right, so how do we know whether or not things are compensated? How do we know all this is occurring? Well, you know by an ABG, and that stands, what does ABG stand for? Arterial blood gas. Exactly. It comes and I just want to let it out. It won't come. I look at the lights. It's not making me. Okay. All right. There are lots of different readings on an ABG printout. Has anybody ever seen one? Ever seen an actual? And I will make you a copy of an actual ABG so you'll know what it kind of looks like. It gives you a whole lot of different numbers. And you're going to get to the point where you will be able to look at that printout and say, oh, they're in respiratory alkalosis or metabolic acidosis or whatever. You're going to see, and you're going to say, oh, they're compensating or they're not compensating or decompensating or whatever. You're going to get to that point where you're able to look at that, and you're going to feel so good about yourself. Okay. What is the normal pH? Y'all remember? 7.35 to 7.45 is the normal pH level. So less than 7.35 is considered acidotic. Greater than 7.45 is considered alkalotic or basic. Hopefully everybody remembers that. Okay? Now, do you remember how I talked about the normal numbers of electrolytes and that occasionally it may be 1 or 2 points off at the hospital because of the way they run it and stuff like that? I'm getting ready to give you some more numbers and it's going to be the same thing, but we're going to go by the numbers that I tell you, okay? All right. So the second thing is partial pressure of CO2. That's how it reads out. It says PaCO2. That's essentially the CO2 level in your blood. Okay, it's regulated by the lungs, and it indicates the amount of bicarbonate that is available to act as a buffer. Now, whether or not this is high or low, CO2 level is high or low, is going to tell you whether or not this is a respiratory condition. You're going to learn that. You're going to see that when we do this name the baby thing. Okay. The normal value of CO2, PaCO2, is 35 to 45 millimeters of mercury. 35 to 45 millimeters of mercury. Okay? Less than 35 is considered alkalosis. Now, see, this is opposite our pH, isn't it? The low end of CO2 is considered alkalosis. Greater than 45 is acidosis. Acidosis. Does everybody still have your sticky notes on your table? What you may want to do now is grab a sticky note, write this stuff on it, these numbers on it, and put it at the top of your desk, because then we'll be constantly referring back to these numbers. I'll say, okay, what is less than 35? And you'll say alkalosis. Okay? So everybody grab a sticky and then write this on it. So the first thing I would write on it is pH 7.35 to 7.45. Okay? The second thing I would write on it is CO2, 35 to 45. And then right below this 35, I would write alkalosis. And right below the 45, I would write acidosis, or however you want to write it. Okay, so you can remember that it's opposite the pH. Okay, now oxygen O2 is going to read out on an ABG, but again, oxygen is not going to let us know whether or not it's a respiratory or metabolic condition. All oxygen is going to tell you is whether or not they are oxygenating themselves well or not. The normal O2 level, and again, this is not going to tell us whether or not it's acidosis or alkalosis, but just for your own information, a normal O2 level on an ABG is 80 to 100 millimeters of mercury. Now, as we age, what do you think happens to that O2 level? It goes down. It goes down with age. So not just condition, but age. Because as we age, we're not able to expand our lungs as we used to. Or, if you've got osteoporosis, that severely decreases the capacity of your lungs. So all those different factors play into it. All right, it's also going to say SaO2. That's the amount of oxygen, or hemoglobin, the amount of hemoglobin that's saturated with oxygen. And SaO2 is exactly what you can get with a pulse ox. You know how you put the pulse ox probe on their fingers and you get a readout? That's what you're getting. You're getting the amount of hemoglobin that's saturated with oxygen in the capillaries. And we're hoping for something above 90. Our goal is above 90. Okay? And then the last thing that you've got, is bicarbonate. And bicarbonate is a direct reflection, the bicarbonate level is a direct reflection of the renal system's ability, the kidney's ability to compensate. Okay, the normal value of bicarbonate is 22 to 26. 22 to 26. Okay. Now, bicarbonate levels match pH levels, whereas CO2 is opposite. And I want you to look at this mnemonic here. This ROME, respiratory opposite, metabolic equal. Okay. So, for example, if the pH is elevated, that's alkalosis. We've already talked about that. If the bicarbonate level is above 26, it's also alkalosis. So it's reversed from CO2. CO2 was opposite. So respiratory opposite, metabolic equal. So if the pH is down, that's acidosis. If the bicarbonate is down below 22, that's also acidosis. So ROME, respiratory opposite, metabolic equal. So on your little sticky, I would write under the 22 acidosis and under the 26 alkalosis, so you remember which way to go. Or you can write ROME. You can do the ROME mnemonic. Okay. Respiratory opposite, metabolic equal. All right. Everybody with me? Okay. Respiratory acidosis. So we're going to start off by respiratory acidosis. Now, let me tell you, the classic picture, I want everybody to hear this, the classic picture of respiratory acidosis is COPD. There's a lot of other things that can cause respiratory acidosis, but the classic one is COPD. And has everybody ever had a COPD patient? They're pitiful, aren't they? They really are. They just cannot breathe well at all. So in respiratory acidosis, the pH is going to be decreased, so it's going to be less than 7.35 because of acidosis. That should tell you that. And the CO2 level is going to be increased because a high CO2 level indicates, remember they're opposite, right? So high CO2, if the CO2 level is up, that's acidosis, right? Because respiratory is opposite. So what's happening is the CO2 is retained. They are not, in a respiratory acidosis situation, they are not able to blow off CO2. They're retaining it. So there's too much, their body is too acidic. Okay? So some of the signs and symptoms, and you see what he's saying up here. He says, I can't catch my breath. These patients feel like they're being suffocated. They're really pitiful. They feel like they're being suffocated. You'll see these patients a lot leaning over the side table, trying to catch their breath. If you lay them flat in the bed, they feel like they're suffocating because they can't expand their lungs. So hypoventilation is what they're doing. They're hypoventilating. Eventually that hypoventilation is going to lead to hypoxia, and their oxygen level is going to be down because they're breathing, they're hypoventilating, but it's very rapid and shallow. So it's kind of like, where they're puffing, but they're not getting anywhere. They're not ventilating their lungs. So it's rapid, shallow respirations. Okay? They have low blood pressure, so they're going to be hypotensive. Because what's trying to happen is the body senses that it is low on oxygen. So it's going to vasodilate. The vessels are going to dilate because it's wanting to get more blood through, but the blood pressure remains low. So it's not high. If you're constricting the vessels, your blood pressure would go up, right? You'd be hypertensive. So the body's sensing my oxygen level is really, really low, so it's going to vasodilate to allow more blood flow. I thought it was going to come that time. It's going to dilate, so allow more blood to flow through, and it's going to cause the blood pressure to be low. So what would you think about when they get up and down from the bed? They're going to have some orthostatics. They're going to be very dizzy with position changes. Okay, dyspnea. What does dyspnea mean? Shortness of breath. They're going to complain about a headache because when the CO2 level goes up, it will cause a severe headache. So they're going to complain of a headache. Hyperkalemia, we just talked about that. If the acid level is too high in the blood, that means there's too many hydrogen ions floating around. Y'all remember that from anatomy? And that will cause hyperkalemia. Dysrhythmias because of the hyperkalemia. Drowsiness, we talked about dizziness, disorientation, muscle weakness. Now there are some other causes, as you see listed down below. Anesthesia, drug overdose can cause this. Pneumonia. But COPD is your classic. That's when you're really going to see respiratory acidosis. That's your biggest thing. All right, so they're breathing rapid and shallow, trying to blow off that CO2. It's not really working because they're hypoventilating. They're not breathing deep enough. So what's going to have to kick in to try to buffer? What body system we're just talking about? The kidneys. So the kidneys are going to try to do what? If it's too acidic, It's going to try to add more base. It's going to try to spill more base. Okay? It's going to try to get rid of the hydrogen ions that are there, the acid that's there, but it's going to try to retain more bicarbonate. Okay, so if I drew an ABG level in this person initially, I would see a low pH, a high CO2 level, and a bicarbonate. If it's trying to compensate, what would my bicarbonate be doing? If it's trying to get better, it's going to be high. It's going to go up as it's trying to compensate for the acidosis. So you're going to see a bicarb level, an HCO3 level, that's high in this situation. I know that's rude, I'm sorry. I can't help it. Now, how do I know that it's fully compensated? How do I know that the respiratory acidosis is corrected? The pH would be back to normal. It would not be less than 7.35, right? It would be somewhere between 7.35 and 7.45. Now, you've got to remember though, if it's a chronic illness like COPD, which is the classic, are they really ever going to be? No. That's the one bad thing about chronic illnesses is that they learn to live in this kind of a situation. Their body just gets used to it. They learn to live in this kind of a situation.
So if it's a chronic illness, they're never going to be fully compensated.
Never going to be fully compensated. You may see some partial compensation. It may get better, but it's not going to get totally better. You may see some improvement. So, for example, if you've got a COPD patient that's admitted to the hospital because they have an exacerbation of their COPD, they come into the hospital, they're treated, they're given some bicarb. We'll talk about that in a minute. They're maybe given some bicarbonate, they're given fluids, and they get some better. That's about the best they're going to get. And they're probably going to send them home because there's not going to be a full compensation. So they're going to live in partial compensation almost all the time. That's why you see nurses that never panic when they have a chronic COPD patient whose oxygen level is 86, 87, 88, because that's where they live. That's their norm. Okay? All right. You think you got that so far? So far, so good? Okay. When we're talking about nursing diagnosis, one of the biggest ones here is ineffective breathing pattern because they're hypoventilating, right? They have rapid, shallow respiration. You could use impaired gas exchange. Let me say something about, this is one of my biggest pet peeves in nursing diagnosis. Impaired gas exchange. You never want to use this nursing diagnosis unless you have an ABG. And a lot of people want to use this all the time. But how can you prove an impaired gas exchange if you don't have a gas report? Make sense? So if you've used that before, okay, but really when you're using it now, please try not to use it unless you really have an ABG result. You can use it if you have an abnormal pulse ox. You may have some patients whose pulse ox levels are low, but they just haven't gotten an ABG for some reason because they don't get them on everybody. You could use it for that because you are telling whether or not their oxygen level is low. But what does it say? Gas exchange. So you really should see both gases. You really should see CO2 and O2. So be really careful with that nursing diagnosis and what it means. Sensory perceptual alterations, they can be confused, headache, dizziness, anxiety. There's a lot of nursing diagnosis you can use. Okay, what do we do for respiratory acidosis? And again, it's kind of like your electrolytes. You have to take care of the underlying problem in order to fix the condition. Okay? So, first off, you have to maintain an airway. You have to make sure that the respiratory tract is free of mucus. You don't want to get any what they call mucus plugs, because if it plugs off with mucus, then they're not going to have adequate gas exchange. So making sure you maintain that airway. Okay? You can administer oxygen, but it has to be low flow. You can actually kill a patient by giving them too much oxygen in this situation. Okay? Now, the standard used to be no more than 2 to 3 liters of O2 for a COPD patient. I have seen some references now that have increased it to 4. But you've got to be really careful with that, because the more oxygen you give them, the more they're going to CO2 they're going to retain. So all you're doing is making the situation worse. Now, again, if you've got an end-stage COPD patient who is already not in good condition, they may be at home living on 5 or 6 liters of oxygen. If it makes them feel better, then at that point, that's end-of-life care. If it makes them think that they're getting more oxygen, then that's what, but it's not doing any good. It's not improving their condition. So the more oxygen you give a patient with COPD or respiratory acidosis, what happens is it shuts down the respiratory drive. Totally will shut it down. And you may actually have a patient who has to go on a ventilator because their respiratory status is totally shut down. Okay. Making sure you're assessing their vital signs frequently, because we're looking for any changes. Remember, we're looking for that low blood pressure. Their respiration level is going to be really high. They may have some tachycardia. Safety is important. Skin and mucous membranes are important. We're looking for cyanosis, signs of cyanosis. Remember that central cyanosis is a late sign. Remember, that's bad. Okay. Oral therapy, the only thing you're really giving orally is to treat whatever the underlying condition is. You can give stuff to decrease the viscosity or the thickness of the secretions. One of the drugs that they use a lot for that is mucomist. And that liquefies the secretions so that they're able to clear them easier. If this is due to pneumonia, then they would give an antibiotic, of course. Inhaled medications such as bronchodilators, because what will that do? Opens up the airways, hopefully to allow more gas exchange to occur. And then educating them. So again, there's not a whole lot you can do for respiratory acidosis except treating the underlying problem, whatever that underlying problem is. Okay? All right, let's do respiratory alkalosis before we go. Respiratory alkalosis is the opposite. A condition where your pH is elevated and your PCO2 is decreased, because that's, remember, respiratory is opposite. The classic picture of respiratory alkalosis is hyperventilation. If you know somebody who hyperventilates from anxiety or fear, something like that. Anybody know anybody that hyperventilates? Really, yes. Paper bag, we have to bring the paper bag. Before a test, yeah. Okay. All right, so the pH is elevated greater than 7.45, and the PCO2 is less than 35. And what happens is there's too much CO2 being lost from the lungs. They're hyperventilating. Some other causes other than hyperventilation are fever. Some high fevers, you'll see especially with children who have a really high fever, their respiratory rate is rapid. aspirin intoxication or salicylate. Ever heard that word? Salicylate intoxication or overdose. Salicylate. If you have somebody that ODs on aspirin, and we've had a lot of overdoses coming in lately in the hospital. Middle school overdoses. Okay. And then anything that causes hypoxemia, such as increased altitudes, shock, excessive mechanical ventilation can cause it. Okay, so a big difference with this one as opposed to respiratory acidosis. With respiratory acidosis, you saw rapid, shallow respirations, right? Here you have rapid, deep respirations. So they're, you see those people that are just, that's not good for me to do, breathing really deep. So they are hyperventilating their lungs. They're overventilating their lungs. Their heart rate is rapid. It's very tachycardic. Blood pressure in this case may be low. It may be normal. That's not going to be a sign and symptom that you really need to memorize for this one. They're going to have hypokalemia as opposed to hyperkalemia. If you've ever known anybody that hyperventilated, they complain of tingling in their fingers and around their mouth. And that's from that excessive loss of CO2. Lethargy, confusion, seizures. Okay, so we have a patient that comes in that's respiratory alkalosis. Their pH is high, their PCO2 is low. So if their body is trying to compensate, what will their bicarb be doing? It's going to be dropping, isn't it? It's going to be dropping because the patient is too basic. It needs to retain more hydrogen ions instead of letting them go. And it needs to get rid of more bicarbonate. So it will be low on an ABG. Your bicarb level, your HCO3 is going to be low if it's trying to compensate. And then how do we know that it's fully compensated? Its pH is normal. The pH is normal. Okay. Your nursing diagnoses are basically the same. Nothing really new. Really, the only way you can control respiratory alkalosis is that paper bag trick. And I know a lot of people we kind of joke about that, but it's really, that's a good way to do it. Because what happens if you get a proper seal of that paper bag and they're breathing in and out in the paper bag, what are they doing? They're trapping that CO2 and they're retaining more CO2. So they're getting more CO2 in, helping that body try to compensate. So the paper bag trick is really the best thing. When I say comfort measures, I mean if you've got somebody who's anxious or fearful, or if that's what's causing it, then you need to calm them down, put them in a calm environment, reassure them. Vital signs and safety, of course, speak for themselves. Drug therapy, whatever the cause is, you need to, so if they need a sedative, oh, finally. Isn't that the worst feeling in the world? You can't sneeze. Or an anti-anxiety medication. And then, of course, educating them on what to do if they become in that situation or what to avoid. Avoiding aspirin products in children, that's a standard anyway. You should never give aspirin to children. But a lot of people don't know that there are other types of medications over the counter that contain aspirin. The original form of Pepto-Bismol contains aspirin. I don't know if anybody knew that, but that's why you never give Pepto-Bismol to a child unless there's a new formula out for children. It doesn't contain aspirin, but the original pink liquid does. So making sure that they know to look for things like that. Again, it's those standard adult medications are not meant to be given to a child, so you always have to look for that. Okay? All right, we're going to stop there because I don't think I can go on anymore. And we will pick up with metabolic tomorrow, okay? Do the acid-base thing.